I request our Director Principal Dr. Vijay V.K. Sir to felicitate our guest of honor, Mr. Balachandran Sir, Chief Engineer of RVS Group of Institutions. We are glad to have you with us, sir.
On this special occasion of National Periodontist Day, I think we have a surprise for our back tour and our support. So as a token of appreciation and the person behind, I think we have a lot of achievements in the past 3 years from the time Sir has joined. So I'm truly grateful, and our department is grateful to our Principal and Director Vijay V.K. Sir, because I think we have achieved so much and we truly owe all the success to you, sir. So huge round of applause to our Principal and Director.
Associate Professor in the Department of Periodontology and Oral Implantology at Dr. HSC Institute of Dental Sciences, Punjab University, Chandigarh. With over 20 years of academic and clinical experience, she has mentored more than 35 postgraduate dissertations and published over 100 scientific papers. A patent holder for a custom design implant for immediate placement, her research spans periosystemic relationship and implant innovations.
An active leader in the Indian Society of Periodontology, she currently serves as its treasurer. We are truly honored to have her with us today. I kindly invite Dr. Vishaka Ma'am to share knowledge on the topic, how gum health shapes your whole body wellness.
Interns, PGs who all are present here. I'm very happy you are disseminating this presentation to the students, because they are the future periodontists of India. So I think it is first and foremost and always good to start early in that journey. And I want to make you know that periodontology traditionally, as it was known to be, that it treats only gum diseases, periodontal diseases, gingival diseases. Nowadays, the discipline is not only limited to that. It has expanded far and wide. A lot of new research areas have started into this, and today's topic we are going to discuss what impact periodontal health or disease has on the general body health. You as a dentist, as a periodontist, how can you impact your patient's health beyond the smile words? Next please. The story which we are going to hear today, actually it's not new. It's long time. The story has started somewhere from the historic times of Romans, Greeks, and Hebrews. But if I tell you scientifically, it was in 1900s for the first time when Miller told focal infection theory. And since then there have been isolated instances or anecdote reportings of such cases or such people where we felt that a periodontal infection is having a bearing on the general body health. If there is an infection in the oral cavity, patient's general health or general body infected is also due. Next please. So before we start this lecture, it is important that you realize what is the difference between focal infection and focus of infection. So focus of infection all of you know, because you have been treating periodontal disease cases, oral disease cases. Focus of infection is any localized area where there is infection, any pus formation, any suppuration, usually near skin or mucous membrane. Such areas are there. Somebody gets infected, a boil takes place, in oral cavity there is an abscess. So it's a localized circumscribed area where there is a lot of infection going on. And focal infection is when this infection from this localized zone travels to a distant area, right? So that is a focal infection. So as I told you, 1900 there came certain instances, but this theory actually went into dispute because at that time we couldn't understand what is the mechanism, what is the pathology behind it. In fact, this area is really an important area which tells you how periodontology, how the research can impact the, change the perspectives of clinicians over time. Next, please. So, 1940s, as people could not find that anything to substantiate such beliefs, so this theory went into, refute. And for next 40 to 50 years, practically there was no work in this area. Now recently in 1980s, there came certain studies from North Europe, where it was seen that people who had periodontal disease in oral cavity, they were more often suffering from cardiovascular disease. Now this was interesting. Next please. Now when these observations came into being for the second time, so it was important that again the theory should not, go in air. It was thought that only and only when there are specific substantial evidence to such cases, then only this process or this concept could be taken into. Next clip, please. So there came this is a criteria of causation from Hill. For any epidemiological studies, we can only find a positive factor associated with the disease causation when all these criteria are fulfilled. So if we feel that periodontal disease is a cause to general body disease, so it must fit in all these criteria. Next clip please. And before we go further, we must understand this diagram, which is basically a diagram where we are talking about the strength of evidence. Evidence, I hope everyone knows. Audience can interact with me. Please, if you are listening to me, please raise your hand. Are you aware of these kinds of studies? The last, at the base of this pyramid is animal or laboratory studies. So they will give you the very, very prime suspicion that there is a risk factor or a causative factor which is associated with the disease. And as we move on to the levels of this hierarchy of evidence, we get to see that if the same observations are repetitively seen in different kinds of study design, then only we are going to believe that probably periodontal disease can be a positive or a risk factor for some general disease. So if, as a clinician I talk, randomized controlled trials are the hallmark of such research. Randomized controlled trials are specifically interventional trials. Do you remember mathematics, how we used to cross-check our answers? When we actually use summation, 3 plus 2 is 5, we will cross-check our answer if it is correct, then we will subtract 2 more from 5 and get the 3 back. So it is, the randomized controlled trials are doing just the same. They are trying to see if periodontal disease is positive for general body disease, whether the treatment of periodontal disease may also help eliminate the general body disease. So if we get such kind of evidence, we are very happy, we are very sure that this disease is associated with periodontal. Next please. Now in 1996, this specific discipline, periodontal medicine, this was a term coined by Steve Oppenheimer, who is popularly known as father of periodontal medicine. This gentleman actually defined this science, which is going to see how periodontal infection or inflammation can affect the general body health. So this term came from a combination of periodontology and general medicine, where infection of gums can be associated with the infection or disease of the body. Next please. Next clip please. And now you will see, or click on next click. Yes. Next one as well. So these all body disorders, if you read Kerenza, you are much acquainted with these kinds of tables in Kerenza. So all these body systems are actually known to be associated or active by the periodontal infection in the body. So this brings a lot of responsibility to periodontists that how we can help these patients not only for treating gingival and periodontal disease but their general body health. Next slide. So now we have a lot of evidence or a lot of knowledge about what are the underlying pathways for this connection. How infection of gum may be responsible for the systemic disease. There are primarily three pathway stages. One is the metastatic infection, where probably bacteria or their bacterial toxins right away will into the bloodstream and reach to a distant zone. Or the bacteremia associated with the dental procedures may lead to presence of bacteria in the blood which reach different areas of the body and may cause infections. The second is inflammation and inflammatory injury. Again, when there exists a periodontal infection, there occurs inflammation of gum and lot rise in the inflammatory mediators. It may again spill back to the bloodstream. That is something which is common, which is flowing through the body unit. So any inflammatory mediators raised at a local area may spill into the bloodstream and may cause a rise in the systemic inflammation, which may help disease at a distance. And adaptive immunity is something. These are few cases where where some parts of our own body, some tissues of our own body are identical to the bacterial structures. Right? What do you call as molecular mimicry? And there is a cross reactivity to your own tissue. Your autoimmunity can play a role where the self is regarded as a bacterial.
Ma'am, I think it was truly inspiring to hear from such a renowned speaker. I think it was a very short notice and still I think you took so much of your time and we're really sorry for the technical glitch we had. I think we wasted so much of your time, feeling very bad about that, but then I think certain things are so much of your time and enlightening our undergraduate students as well as postgraduate students, ma'am. So I think this is a topic which is of great importance now because being periodontists, we are not just focusing on the oral cavity, we are kind of the entire well-being of the person is very important. So I think we got a lot of recent updates also, ma'am. I'll just give it to sir for a minute.
Sir, ma'am. I hope our students have got the knowledge of the periodontal things. Thanks for everything. And meantime, we'll be calling you as a guest to our college also, ma'am. So please accept that also.
Thank you so much.
And we'll be very happy to receive you here always, ma'am.
Can I just say a word, the last word to the audience?
Sure, please.
One is that I think the lecture is important from clinical practice for all of us because majority of patients we come across are medically compromised. So I think periodontist is someone who comes in touch with these people very often in dentistry for kids to sit in the exam. So that is why I try to bring two things. And last of all, Coimbatore is very special to me. Always I would want to be there. That Isha calls me many times. Isha, you will help.
Yeah, we are always here and our college has a well connection with the Isha here. And whenever the examiners or inspectors come over here, we always take them to the Isha always. So always welcome, always welcome. Okay.
Look forward to.
Yes, sure. On behalf of our department, ma'am, I will give you a memento. And it will be courier to you, ma'am. Please accept that. Please accept that. Thank you very much.
Thank you so much. Thank you, Rajshekar sir. Glad to see you, meet you here. Hope to meet you in person soon.
Thank you so much.
And all of the best for you.
Yes, ma'am, we are expecting you soon in Coimbatore, ma'am. Thank you so much.
Thank you. Good day. All the very best for the
Thank you.
Experience including 17 years as a professor, he has made remarkable contributions to academic dentistry. He completed his BDS and MDS from Raja Muthiah Dental 84 scientific and deliver numerous guest lectures at national and international forums.
He is the recipient of Outstanding Researcher Award 2023 and actively serves in various professional bodies, including the Indian Dental Association and Indian Society of Periodontology.
Greetings from Rajamutte Dental College and Hospital. We always be very fond of calling our college as Rajamutte Dental College, as Professor Vijay said. Presently, though, we are in government, called as Tamil Nadu Government Dental College and Hospital, Kannur district. I thank the Organs Dental College, especially the Perio department, giving me this opportunity. So today, I think the audience is comprised of both undergraduate and postgraduate students. The essence of my lecture is going to be the challenges in diagnosing the periodontal disease, how we proceed with treating the periodontal disease by especially surgical methods, because the department wanted me to be more specific on flap surgeries. So most of the time the undergraduates are confused, the practitioners are confused why to do a flap surgery and when to do exactly, when to go for a surgical therapy. So I'll be very happy if I'm able to clarify to the undergraduate students what is the importance of surgical periodontics and when exactly you should shift from non-surgical to surgical periodontic once you diagnose the patient as having periodontitis. So to give a brief introduction, all of you know that the primary etiological factor for periodontal disease is a dental block biofilm. That is, different species and different genera of microorganisms that are encompassed within a matrix, extracellular matrix. Normally, I'm able to see a lot of private practitioners, they advise mouthwashes to the patients without doing the basic non-surgical scaling and root planing. They do not concentrate much on meticulous scaling and root planing. They leave a lot of block biofilm and advise the patient to use mouthwashes. A lot of students who are here, take-home message is never use mouthwashes as a permanent remedy for treating periodontal disease. You have to intercept and remove the biofilm. That is the most important thing. Unless and until you resolve the inflammation present in the gingiva, you will not be able to arrest the progression of disease. So mouthwashes cannot be used like a scent. It is just like my mentor and my professor, Maithili Madam already, principal of Vijay sir mentioned. Maithili Madam used to say that using mouthwash without doing a proper scaling is like without taking bath, you apply a scent on your body, perfume in the body, like that it is. So the disease will stay back in the oral cavity and you will be just arresting the signs of the disease by using mouthwashes. So block control should be the essence of your baseline treatment. To remove the bacterial biofilm. So as you know that as long as the block stands there in the oral cavity, it induces more and more of gingival inflammation, further leads to pocket formation, and when the pocket deepens, there will be even more abundant block accumulation. So that leads to destruction of collagen fibers and periodontal tissues. So the basic idea why we are giving a quota of 50 cases of scaling in your UG time is you should be thorough with professional biofilm control. A lot of times what happens is you take up very simple cases like 1 plus B, here we call it as 1 plus 2 plus calculus. I don't know about there. Here we used to write in the case sheet 1 plus 2 plus cases. Most of the students prefer to take simple plus calculus where almost with a clean mouth you don't learn anything. Take up patients with heavy block and calculus, remove the block and calculus, get yourself trained. Most of the times the mistake what we do is, in the interproximal areas of the tooth, we neglect doing scaling. Because we find it difficult to remove the block, we leave the block there, that leads to pocket formation and periodontal destruction. So periodontal pocket is the most common sequelae of chronic periodontitis, and most of our treatment are directed either to eliminate or to reduce the pocket depth to a maintainable level. One thing you should remember is pocket elimination procedure is not required for patients who respond well to non-surgical therapy. If you are doing a very good scaling and root planing, and if the pockets subside to a normal sulcus depth level, you need not proceed to surgical therapy. So this you should always keep in mind. That's why I told in the beginning of the lecture when you should stop short with non-surgical therapy and when you should proceed with your surgical therapy. So before going on to the periodontal flaps, you should always be able to diagnose the condition. That's why the case sheet writing is an important component of your undergraduate curriculum. Whether it's oral medicine or periodontics, orthodontics, and especially periodontology, you have to undergo a rigorous training in how to diagnose a patient by doing an elaborate oral examination and periodontal examination. Even in a general practice, even if you don't do periodontology, if you're going to do some other specialty and proceed with your practice, always make sure that your diagnostic armamentarium contains a graduated periodontal probe. Be it a Williams periodontal probe or a UNC15 probe or whatever it is, you must mandatorily have a periodontal probe. Unless you probe the sulcus all around the tooth, you will not be able to identify the disease in its initial stage. So identify the disease in the initial stage and interfere so that the disease doesn't progress. So by that you can always prolong the tooth and improve the prognosis of the patient. So once you encounter a pocket, make sure whether it's a localized disease or is it a generalized disease, what is the depth of the pocket. Sometimes the pocket depth is just 4 mm or 5 mm. You can do a non-surgical therapy and arrest the disease. And nowadays you have an excellent racy set of curates. After-5, they call it as after-5 curates, which I will be showing in the subsequent slides. Even more than 5 mm pockets, you can do a meticulous non-surgical therapy by using these after-5 curates. I think all of you should be aware of this as it is given in the Karamsa textbook. And in spite of your meticulous non-surgical therapy, if the pockets and the symptoms does not subside, if the inflammation persists, if the bleeding on probing persists, if the pockets are not reduced to the physiological level, then you should always think about going to the surgical phase. So the importance of periodontal surgical phase is you need to eliminate the pathologic changes in the walls of the pockets of the shoulder, okay? So that you create an easily maintainable stage which is stable, and if possible you can also do some periodontal regenerative procedures by doing a flap surgery. The surgical pocket therapy helps to eliminate the pathologic changes in the pocket wall. So to fulfill these objectives, these techniques increase the accessibility to the root surface, because you need accessibility to root surface to remove the toxins. It helps in eliminating or reducing the pockets to a normal physiological level, and by opening the flap you can always do reshaping of the cord tissues to get a harmonious topography. So these are all the objectives or purpose of your surgical pocket therapy. So once again, many postgraduate students are also here. How do you justify, whenever an examiner asks you, how do you justify that you are going to do a flap surgery for this patient? Because after phase 1 therapy, you have waited for a certain period of time, there is good signs of improvement. So can you wait even more longer? Always say that I have waited for 1 to 3 months after my phase 1 therapy, and still there are infra-bony or deep pockets present in certain areas which are inaccessible for non-surgical therapy. So I am going to go for a flap surgery. Meaning, after completion of phase 1 therapy, a final call should be made after thorough evaluation of the effects of the phase 1 therapy. In my clinic, what I do is, if I get 20 cases of periodontitis, normally I go into surgical phase for only 5 or 6 or maximum 8 to 10 patients. The rest of the 10 patients, they get better with the non-surgical therapy. I don't mind losing the patients, I don't mind losing my income through the surgery, but doing justice by not jumping into conclusion that all patients need a surgery. So that's why you wait for a sufficient period of time, at least 1 to 3 months after doing a very effective phase 1 therapy. In most of the patients, if the pockets come back to the normal level, you put the patient on routine maintenance. If the pockets does not subside even after 1 or 3 months, then you go for your phase 2 or surgical phase where you open up the flap. So you can justify that after meticulous phase 1, you see the bone or you don't want to see the bone. Whether you want to place the flap accordingly in the same position or you want to position the flap in a different position. How do you manage the interdental papilla? Whether you want to preserve the papilla or split the papilla. So based on that, flaps are classified as full thickness flap. Based on bone exposure, it can be a full thickness flap or partial thickness flap. Sometimes you have to mandatorily expose the bone to do some regenerative procedure or resective procedure. In that case, you have to go for a full thickness flap. If there are no pockets, the main ambition is to displace the flap without seeing the bone. You can go for a partial thickness. Similarly, non-displaced flap. The flap is returned to its original position and sutured back, called as a non-displaced. If you want to move the flap away from its original position, either apically or coronally or laterally, call them as displaced flaps. So non-displaced or displaced flaps. This is the conventional flap and the papilla preservation based on how you deal with the interdental papilla. Interdental papilla is a very, very delicate issue. If you handle it properly, the aesthetics will be preserved. If you don't handle this tissue properly, the aesthetics is going to be compromised. So what happens here is the papilla is split, palatal and the buccal papilla is split. Then the flap is reflected. This is called as a conventional flap. The disadvantage is in the aesthetic areas, the upper anterior zone, there can be some amount of papillary recession. And what happens when the papilla is receded? It causes a black triangle. Aesthetically, it is compromised. So to avoid that, if you have adequate interdental space in the anterior region, you can go for a papilla preservation flap. So let's skip few slides to save the time. So the conventional flap includes modified retinal flap, undisplaced, apically displaced flap, and certain flaps for regenerative procedures. So how do you select the flap technique? Patient is given to you, patient is diagnosed as periodontitis, you have done a non-surgical therapy, the pockets have not subsided to the satisfactory level, so you have decided to go for flap surgery. So how do you decide which flap technique is ideal or better for this particular patient and especially for this particular quadrant? This should be selected based on the simplicity, predictability, efficiency, mucogingival considerations and based on the underlying osseous topography. Technique should be simple to perform, don't do some complicated procedures unless you are well trained. It should be predictable. Don't jump in a conclusion that you can do all procedures for all patients. It should be predictable, it should be efficient for the patient. Give consideration to the mucogingival complex. If there is no adequate zone of correctness issue, don't go for any receptive procedures like undisplaced flap or any excessive resection of the gingiva. So always follow the basic principles in the design of the flap that can avoid flap necrosis, that can avoid flap dehiscence and tearing, and always you have to avoid injury to the anatomic structures present in the close proximity. So all your incisions should be clean and complete. Most of the times the problem arises here. Don't give a clean incision, give an incomplete incision, and bits and pieces of flap you are raising, there will be a lot of flap tearing and a lot of hemorrhage or bleeding. So flap should be designed to retain maximum correctness tissue. There should be adequate access visible, available whenever you design flap. Try to avoid uninvolved adjacent areas. If adjacent areas are not involved, just for the sake of convenience, do not reflect flap in that area also. You have to modify your flap design. And base of your flap, this is a component always you should have taught in the department and the college. The base of the flap should always be wider to allow adequate vascular supply. So this is the base and length of the flap. The base should always be wider to permit adequate vascular supply. So whenever you give a releasing incision, always give a releasing incision like this, not like this. So the base should be wider. You can see here, this is the releasing incision told you, don't give in the mid radicular surface, always give in the line angles. This is another photograph showing how the base should be wider compared to this. So whenever you give an incision, the bevel of the blade should be angled properly and it should hit the crest of the bone. You should feel the crest of the bone whenever giving incision. That will avoid incomplete incisions. If you give an incomplete incision, only the partial thickness flap can be elevated. Periosteum will be retained. That will cause excessive or profuse bleeding. So you cannot do adequate debridement whenever there is a profuse bleeding. Most of the times the postgraduates are doing this mistake. Always elevate give the incisions properly. Once a good incision is done, 20 to 30% of your work is done. So a firm continuous stroke should be used. Long continuous strokes are preferred to short ones. So continuously you keep on excising the area after feeling the crest of the bone. So avoid multiple incisions in the same area. If suppose you are giving internal bevel incisions, if you are going to give two different internal bevel incisions out of mistakes, the flap will be, the elevation will be very difficult and compromised. So whenever you encounter, sometimes you encounter edentulous area in between. So what happens is, you do a separate flap opening here, you do a separate flap opening here, you neglect this area. What happens is, the clot and granulation tissue will stay back in the interproximal areas and it leads to recurrence of the disease. So you connect these trabecular incisions with a mid-ridge incision. So inter-ridge incision should be given to connect these two different flap designs, and this area should always be open to gain access to the proximal surfaces. So extent of surgery, this is another important thing. Avoid flap tension. To avoid flap tension, you should always include two teeth on either side of your flap design to avoid a tension on the flap. Suppose you are doing a very short span of flap surgery, to avoid tension you can go for a vertical releasing incisions. Again, how much the flap should be exposed, how much the flap should be elevated and expose the bone. Many times we are confused whether we have elevated it enough or not. Ideally, 1 to 2 millimeter of healthy bone exposure is enough. Don't overexpose, don't underexpose. Ideally, 1 to 2 millimeter of healthy bone exposure is enough. Suppose if you have a deep intrabony defect, deep osseous defect, in that case you can expose more amount of bone. Otherwise, don't unnecessarily overexpose or underexpose. So ideally 1 to 2 millimeter of bone exposure is ideal. Suppose if you have a deep intrabony defect like this, then you have to elevate and expose the entire topography of the defect. In that case, you can expose 3 to 4 millimeter of bone. So design of the flap is always dictated by the surgical judgment of the operator based on the necessity and degree of access to the underlying bone and root surfaces. So it's never the same for all the patients. So these are the different flap designs: Whitman, modified Whitman, Kirkland flap, envelope flap, and displaced and displaced flap. Most of the times, most of the practitioners do this Kirkland flap. I'll tell you why, what is the reason. Then there is a papular preservation flap, as I told you in the beginning. So envelope flaps, what is an envelope flap? How do you open a postal envelope like that without giving any releasing incisions, with only the horizontal incision? If you are elevating the flap, that is called as envelope flap. If you do a flap for the entire quadrant, you can do this envelope flap. You will have sufficient access to the underlying bone and root surfaces. This is the example of envelope flap. The entire quadrant, the flap is elevated. Nowhere the releasing or vertical incision is given. So you can see the exposure of the bone here and also the root surfaces to do the debridement. Then this is the Whitman flap, where internal bevel incision is given and 2 vertical incisions are given. This is the original Whitman flap proposed by Whitman, Leonard Whitman. And certain authors like Ramford and Nisley, they modified this Whitman flap. The internal bevel incision is given but no vertical releasing incision. That is the main difference between original Whitman and modified Whitman flap. After the first internal bevel incision and the second interdental and the third trabecular incision, this wedge of the tissue, the collar of the tissue where the pocket lining is there, the tissue is removed and then the flap is elevated, adequate debridement and curating is done, root padding is done, and the flap is sutured back at the tooth bone junction. You can see the sharp margins, sharp gingival margins, and a very good adaptation to the tooth bone junction. There can be suture related complications. Sometimes the sutures can wick the oral bacteria inside the tissues. That's why we protect the area with a periodontal dressing. And if you fail to remove the sutures on time, it can lead to scar tissue or other epithelial and suture related abscess. So always recall the patient after 1 week or 10 days, inspect the area and the surgical instruction should give to the patient verbally as well as in the written format. Apply cold compression or cold fomentation extraorally or externally after surgery, immediately after surgery. Paracetamol or any analgesic can be given twice or thrice a day for 2 to 3 days. Avoid taking any hot or spicy food for the first 24 hours. The patient can start rinsing with chlorhexidine mouth rinse, antimicrobial mouth rinse after 24 hours after surgery, twice daily. And avoid smoking till the tissues heal. If the pack is given, if you are given a periodontal dressing, advise the patient not to brush over the pack because the pack should ideally stay there for a week. And as I told you earlier, the patient should be recalled after 1 week. And if you feel that the healing is adequate, you have to remove the sutures. So the causes of failure: poor patient selection, improper or incorrect diagnosis, and the patients do not follow your instructions. These can be the causes for failure. The most important cause is incomplete debridement by the surgeon. So always be familiar with the causes of failure, identify the cause and then act accordingly. So one small example again I can give you is, this happened 4 or 5 years back in our department. There was a surgery to treat gingival recession. One girl postgraduate did a subepithelial correct tissue graft taken from the palate, and it was a beautiful surgery. Photographs were taken and I was really wondered how this postgraduate was able to do this so beautiful root coverage procedure. But unfortunately, the graft procedure failed. In spite of following all the surgical principles, the grafting was a failure because the patient did not listen to the advice. The patient continued smoking from the second post-operative day. The patient did not stop smoking in spite of our repeated warning. So what happened is the graft tissue got necrosed. So such patients try to avoid complicated surgeries. So to summarize, the periodontal flaps are frequently done with good results. Should be done only after your thorough phase 1 therapy in a well-motivated patient. Never compromise on your scaling and root planning. All the basic principles should be adhered. Treatment plan and surgical design should be well planned, meaning the planning is very, very important. It's the blueprint. Then complete removal of all local factors, which is the mantra or key to your success. Recurrence should be avoided with your proper maintenance. It's not like how they tell in the advertisement for Kirahota, like fill it, shut it and forget it. Not like that. You recall the patient periodic intervals to prevent or avoid recurrence of the disease. Because most of the practitioners, they avoid doing periodontal surgery, and the common complaint they say is, whatever we do, there is a recurrence. But the failure is because of not recalling the patient for maintenance. So these are the references for your future reading, at least for the undergraduate students. I hope I was able to live up to your expectations. I thank the organizers for giving me this opportunity. Unfortunately, I am not able to be there in person, even though I wanted to be there because of some hectic traveling. So to succeed in your mission, you must have a single-minded devotion to your goal. This is my favorite Abdul Kalamji's quote. Thank you for your patient listening. If the students have any doubt, the organizers can ask me or they can mail me to this mail. Thank you so much.
Thank you, Dr. Rajashekar sir, for your enlightening lecture. Your virtual presence has truly enriched our celebration, sir. We take this opportunity to display our token of love virtually.
you very much.
Is there, generally it's like 6 weeks, 4 weeks to 6 weeks is usually what we advise. So is there like any new reference where we could quote, sir? Like
Even in Karaksa it is given 1 to 3 months, 1 month to 3 months. As I said, it's 6 weeks. Sometimes
Yes,
it can extend up to 3 months. Some patients, the inflammation they persist because of based on their post-immune response.
yes, sir.
And nowadays, a lot of viruses and different genera of bacteria are associated. They are
Yes.
very resistant.
Yes.
So in such cases, you can wait up to 3 months. In medically compromised patients where the inflammation is not subsiding, even you can wait up to 9 months.
Okay, so
This is what
generally
is
it's
given
better to
as-
say that they waited for 3 months, like in the postgraduate exam.
Yeah, 1 to 3 months. At least minimum 1 month.
Okay, sir. Okay, sir. And also the protocol of antibiotic is like only on the medically compromised, it's always advisable. No? So if you are following the strict
Yes.
protocol,
Yes.
it's not required.
Yeah, it's not required. Not required for all the patients.
Yes, yes. It was truly enlightening session, sir, and we would love to have you with us in person, but I think because of your personal commitments,
Yeah, yes.
it's not possible.
Definitely. Some other occasion I will definitely come.
Yes, sir, but I think it was a really elaborate session because you told 45 minutes, but I think you took more time and tried to explain every detail right from the diagnosis to the post-operative. So I think it is truly beneficial. We are having an afternoon session in the sheep mandibles, so on the flap as well as PRF protocol. So I think it would be very useful for the postgraduates as well as Indians. I'll just give it to sir.
Seeing you in our college and in my screen, and I thought of calling you in person, and as I said, because of personal commitments it could not be done. And thanks for everything, sir. Thanks for everything, and thanks for the lecture what he has given today, and it was given to me before also. Thank you very much for everything, sir. Thank you.
Thank you, thank you, Vijay. Thank you. Wish you all the best for the future programs. Thank you.
Sure, sir. Sure, sir. Thank you very much, sir.
It's not just a tradition, but a way of encouraging dedication, hard work and commitment. Today we honor those who have demonstrated outstanding performance and enthusiasm. I respectfully invite our esteemed principal, Dr. Vijay V.K. sir, along with our honorable chief guest, Mr. Balachandran sir, Chief Engineer of RVS Group of Institutions, to give away the prizes.
Competition conducted by Masa University. Huge round of applause. Thank you, ma'am. Next up, I call upon Dr. We would also like to acknowledge Dr. Soumya, postgraduate student of batch 2021 to 2024 in academic attitude and attendance.
So in the Department of Periodontology, we usually acknowledge not only academics, I think all of you know, it's the attitude as well as the attendance. So that's a AAA award, so it's awarded to Dr. Harika. Please do round of applause. So she's been a very sincere, hardworking student, and we just wish her all the best for her future endeavors.
Who was awarded with ISP Implant Research Grant and Commendation Award for poster presentation via video conference.
This is the ISP grant, research grant. So I think we are truly privileged. It's the first time our college has been awarded with a grant, and I think the ISP as well as principals has been very supportive. We've got a grant of 2.5 lakhs, that is including the implant and about handpiece with 30 implants. So we truly appreciate and we encourage the further postgraduates to also take part. So huge round of applause, a true achievement from the postgraduates.
Followed by Dr. Vimita, who has received the second top position in the first year PG exams of the year 2025.
Harshita from the CRA batch 2024-25 to the stage.
We have a couple more prizes from the PFA conference. I call upon Dr. Kavi Prem, second year PG, securing first place in paper presentation. I call upon Dr. Gauri, second year PG, who has secured second place in paper presentation. Followed by Dr. Samina from the CRA batch for securing second place to the stage.
We had conducted multiple competitions over the last week on the occasion of Periodontist Day. To give away the prizes of Rangoli competition, I call upon Dr. Aparna ma'am to the stage to give away the prizes along with Principal Sir and HOD ma'am. First prize is backed by Anjushree, Aruna and Achaya.
Second prize is backed by Bhavadarani Shri, Deepika, Anupriya. It is also shared by Anushya, Abhinaya and Manjureka. Varshni and Shri Riya. It is also shared by Anu Kirtana, Kartika and Joyce. A huge round of applause, please.
To give away the prizes for online Instagram Reels competition,
Second place is shared by two teams, Nazira Fatima from final year and Dr. Nivedita, first year PG.
Precision is key. A periodontist sees the vital details that others might. By protecting your gums, we shield your heart, your lungs, and your entire system. Comprehensive care brings more than a smile. It brings the confidence of true vitality and lasting health. Your mouth is the gateway to your health. Trust the guardian. Protect your journey beyond teeth.
ஏன்னா வலியே இல்லாமல் நம்ம பல்லை டேமேஜ் பண்ணக்கூடிய பெரியோடன்டல் இன்ஃபெக்ஷனை நம்ம டென்டிஸ்ட் ஆகிறதுனால கண்டுபிடிக்கணும். இந்த ரெகுலர் டென்டல் செக்கப்பில் நம்ம பல்லில் எப்படி கேவிட்டிஸ்லாம் இருக்குன்னு செக் பண்ணுவாங்களோ அதே மாதிரி உங்கள் கம்ஸில் ஏதாவது இன்ஃபெக்ஷன் இருக்கா அப்படின்னு சொல்லிட்டு பெரியோடன்டல் ப்ரோப் அப்படிங்கிற இன்ஸ்ட்ருமெண்ட் மூலமாக உங்களோட கம்ஸோட டெப்த்தையும் மெஷர் பண்ணுவாங்க. ஒருவேளை ப்ளீடிங் கம்ஸோ இல்லை கேல்குலஸ் ஃபார்மேஷனோ இல்லை பாக்கெட் ஃபார்மேஷனோ இருந்தால் அதாவது இது போல் ஏர்லி பெரிடான்டல் சிம்டம்ஸ் இருக்குனாக்கா அதை உடனடியாக ட்ரீட்மெண்ட் பண்ணுறது மூலமாக அது ஃபர்தராக ப்ராக்ரஸ் ஆகாமல் ஒரு டென்டிஸ்ட்டை நம்ம தடுக்க முடியும். ட்ரீட்மெண்ட்ஸ் என்னென்னங்கிறத நம்ம என்ன பார்க்கலாம். நமக்கு போன்லெஸ் ரூட்டோட நடுப்பகுதி வரைக்கும் வந்துருச்சுன்னா ஸ்கேலிங் அண்ட் ரூட் பிளானிங் பண்ண மட்டும் பத்தாது. ஏன்னா அந்த கம்ஸ் எல்லாம் பாக்டீரியாவால் இன்ஃபெக்ஷன் ஆகி கிரானுலேஷன் டிஷ்யூ இந்த நிலைமையில் ரணமாக இருக்கும். இது பல்லோட திரும்ப ஒட்டாது. இது 2 விதத்தில் ட்ரீட் பண்ணலாம். ஒன்று ட்ரெடிஷ்னலாக கம்ஸை ஓப்பன் பண்ணிவிட்டு சர்ஜரி பண்ணிவிட்டு ரூட் பிளானிங் பண்ணிவிட்டு கம்ஸில் தள்ளி போடுறது, இது ஒரு மெத்தட். 2வது லேசரோட டிப்பை உள்ளே கொண்டு போயிட்டு அந்த கெட்டு போன கம்ஸை மட்டும் பொசுக்கி எடுத்துட்டு கம்ஸை திரும்ப டைட்டன் பண்ணுவதும் லேசர் மூலமாகவே பண்ண முடியும். இது அட்வான்ஸ்ட் மெத்தட். ஆனால் இந்த மெத்தட் மூலமாக பாக்கெட்ஸ் மட்டும்தான் வெளியே பண்ண முடியும், தவிர போனை வளர்க்க முடியாது. அப்போ போனை வளர்க்கறதுக்கு என்ன பண்ணணும்? எலும்போட பெருமானம் ரொம்ப குறைஞ்சதுக்கப்புறம் நம்ம கம்ஸை மட்டும் டைட்டன் பண்ணால் பத்தாதுங்க, எலும்பையும் திரும்ப வளர்க்கணும். நம்ம யங் ஏஜில் இருக்கோம், போனஸ் கம்மியாக தான் இருக்குது அப்படின்னாக்கா க்ளீனிங் பண்ணிவிட்டு ஹெல்த்தியான கம்ஸை உருவாக்கினாலே போதும், எலும்பு தானாக வளர்ந்துடும். ஆனால் இப்போ நம்ம மிடில் ஏஜ் தாண்டிட்டோம், போனஸ் ஜாஸ்தியாக இருக்குது அப்படின்னாக்க அப்போ இது மட்டும் பத்தாது, போன் கிராஃப்டிங் பண்ண தேவைப்படலாம். ஈரை இறங்கிருக்கிறவங்களுக்கு கம்ஸு கூட கிராஃப்டிங் பண்ணி கம் கிராஃப்ட் மெத்தட்டை ட்ரீட்மெண்ட் பண்ணலாம். எல்லாத்துக்கும் கல்டிவோடான நாங்கள் கைடட் டிஷ்யூ ரீஜெனரேஷன் சொல்லுவோம்.
bleeding lips. கொஞ்சம் அதை பற்றி ஷேர் பண்ணுறீங்களா? கண்டிப்பாக சொல்கிறேன். Bleeding lips, which leads to periodontal usage. Usually, எந்த ப்ளாக்ங்கிற ஒரு விஷயம் டூத் நல்லா போயிருக்காங்க. இந்த ப்ளாக்ல இருக்க பாக்டீரியா டாக்ஸின்ஸை ரிலீஸ் பண்ணி கம்ஸை இன்ஃப்ளமேஷன் ஆகுது. அதனால நமக்கு ஜின்ஜைட்டிஸ் வரும். இந்த ஸ்டேஜில் ப்ராப்பராக ஓரல் ஹைஜீனை மெயின்டைன் பண்ணோம்னா இந்த கண்டிஷன் ரிவர்சபிள் தான். இதை நம்ம கண்டுக்காமல் விட்டுட்டோம்னா இன்ஃபெக்ஷன் டீப்பராக இருக்க சப்போர்ட்டிங் ஸ்ட்ரக்சர்ஸ் லைக் பெரியோடான்டல் லிகமெண்ட் அண்ட் ஆல்வியோலர் போனுக்கு ஸ்ப்ரெட் ஆகி இந்த கண்டிஷன் இயர்லி பெரியோடான்டைட்டிஸாக டெவலப் ஆகும். இதனால ஜங்ஷனல் எபிதீலியம் எபிக்கலாக மைக்ரேட் ஆகி பெரியோடான்டல் பாக்கெட் ஃபார்மேஷன் நடக்கும். As the disease progress, connective tissue destruction and alveolar bone loss increase ஆகி moderate to severe periodontitis வரும். இதனால attachment loss, even tooth mobility கூட நடக்கும். இந்த periodontal disease local problem மட்டும் இல்லாம பாக்கெட்ல இருக்கிற பாக்டீரியா blood streamsக்குள்ள enter ஆகி பாக்டீரியாவுக்கு காஸ் பண்ணுது. இந்த systemic inflammatory response increase many disease like diabetes mellitus, cardiovascular disease and infective endocarditis, adverse pregnancy outcome, respiratory disease இந்த மாதிரி நிறைய டிசீஸோட ரிஸ்கை இன்க்ரீஸ் பண்ணுது. Periodontal infection is not only an oral health problem but also a periodontal risk factor for various systemic diseases. என்னதான் சொல்ல வரீங்க? ஒண்ணுமே புரியல. இதுக்கு சொல்யூஷன்னா என்ன?
சொல்றேன் வாங்க. ப்ளீடிங் கம்ஸ் தானே விடாம ப்ளீடிங் கம்ஸ்னு விட்டிங்கன்னா நான் முன்னாடி சொன்ன மாதிரி ஜின்ஜைட்டிஸ், பெரியோடான்டைட்டிஸ்னு இதோட அடுத்த அக்ரெசிவ் கண்டிஷன்ஸ் வரும். இது உங்க வாயை மட்டும் சேதப்படுத்தலைங்க, உங்க உடலையும் சேர்த்து தான் சேதப்படுது. இதனால நான் என்ன சொல்ல வரேன்னா பெரியோடான்டிஸ்ட் கிட்ட ரெகுலராக செக் பண்ணுவோம். தேங்க்யூ.
Next up, we have the winners of the placard designing competition. The first prize Mara, Babu Ganesh and Sandhya from Intern. Second place is also shared by 2 teams, Harini, Kanati, Anuhasini and Brinda.
Thank you, sir and ma'am. Next up, I call upon Dr. Pradeepa ma'am to join us on stage.
A huge round of applause, please. Mrs. Amuda. Mr. Alabir Sami.
Respected dignitaries, honored of the dais, and head of the departments, faculty members, and dear students, with hearts full of joy and gratitude after this wonderful celebration of Periodontist Day, and with the blessings of Almighty and from our Honorable Chairman, Dr. K.V. Kuppusamy Ayya, I take this opportunity to convey my vote of thanks. First and foremost, I express my sincere gratitude and thanks to our respected and beloved Principal, Director Dr. Vijay D.K. sir, for his constant support, encouragement and visionary leadership that made today's program successful. I express my sincere gratitude and thanks to our respected Chief Engineer, Mr. Balachandran sir, for his constant support and encouragement in all the academic events. I extend my heartfelt thanks to our Honorable Chief Guest, Dr. Vishaka Grover ma'am and Dr. Rajshekhar sir, for graciously accepting our invitation and sharing valuable thoughts with us. Your presence has truly enriched the occasion, sir and ma'am. My heartfelt thanks to our beloved HOD, Dr. Deepshika Sharona ma'am, whose dedication and meticulous planning and continuous efforts ensure a smooth flow and the success of every event. I would like to extend my thanks to our respected administrative officer, Mr. Rajagopal sir, for his continuous support and for the proper conduct of the event. I also convey my deep appreciation and thanks to our department faculty members, Dr. Sendil Kumar sir, Dr. Sakti Ganesh sir, and Dr. Vinu sir, and Dr. Vaishnavi, Dr. Abarna, and Dr. Pradeepa for their constant support in organizing this event and their commitment towards academic and clinical excellence in periodontology. I extend my thanks to our postgraduate students and interns and all the volunteers whose planning and teamwork made our today event successful. I also convey my thanks to our department paramedical staff, technical and non-technical supporting staff for their unconditional support. And I also thank Sulur Media and Netway for their support, and I would also like to congratulate all the prize winners. Then last but not least, I thank each and every student who participated in this event, and this made that event a gracious and good event and truly memorable event also. Thank you once again and have a nice day.